Hello, everyone. Can you hear me okay? All right, great. Welcome to the lunch session that I'm very grateful to the council and the program committee, Tony Yang, for having us do this ergonomic session during lunch. So surgery is a pain in the neck and other places. I'll let you decide what those places are. My name's Geeta Lal, and I will start off this panel with a small talk, followed by Andrea Merrill, followed by Phil Haigh, and then hopefully we'll have time left over for questions at the end. I'm sure we can't cover everything there is to know about surgical ergonomics in the next little while, but we'll try to hit the high points and be ready for some interaction or interactive sessions, so we'll get going. So first off, some disclosures and disclaimers. As I mentioned, I am an endocrine surgeon. I don't have any consulting or financial relationships with industry, but I do own a speaking and coaching business. And I'm the co-founder and current president of the Society of Surgical Ergonomics. Dr. Merrill didn't have any conflicts of interest to disclose. Dr. Haigh is also a co-founder and the current treasurer of the Society of Surgical Ergonomics. The other thing is that we aren't physical therapists, occupational medicine physicians. We're surgeons like all of you, and we're going to share our own experience and what we've learned along our journeys. So I'd like to start off with sharing a little bit of my own story. Some of you know that in late 2016, early 2017, I struggled with a lot of jaw pain and was actually diagnosed with myofascial temporomandibular joint dysfunction, which means too bad, you grind your teeth, use these NSAIDs, a mouth guard, etc. Well, what I didn't know at the time was that the origin of that pain was actually not my jaw. There was nothing wrong with my jaw, but rather the jaw hurting was a fourth level compensation for, or the tip of the iceberg for a number of injuries that I had had over the years, both at work and outside of work. The immediate precedent was a fall at home, resulting in a rotator cuff injury and frozen shoulder on the same side. Prior to that, a couple of disc herniations, the first one in training, and then a motor vehicle accident as well. So the other thing, as I said, I learned along the way was that the biggest driver of my symptoms and those of most surgeons is something called a forward head posture. And what do I mean by that? So the figure there that I'm highlighting on the left is taken from a paper that's describing the epidemic of text neck. We're all walking around with our mobile devices with our heads flexed forward. What that does is you can see that just a slight forward flexion, maybe 15 degrees, essentially doubles the weight of your head at the top of your spine. And in my situation, with the levels of compensation, essentially with injuring my spine and then my shoulder, the muscles in my jaw were focused on trying to stabilize the top of my head or stabilize my head at the top of my spine, and hence I was having muscular jaw pain. So this, piqued my interest. I was intrigued to learn more. I wanted to know, was it just me, or is this more widespread? So this is the biggest sort of analysis I could find. Now you have to remember, we don't have great data. It's all survey-based. This is a meta-analysis published by another endocrine surgeon. At that time, she was in training, Dr. Chichi Stuckey, and it looked at over 5,000 surgeons. Almost 70% reported pain from operating, and when you looked at the site of injury or site of symptoms, the usual culprits, neck and back, top heavy hitters, followed by arm and shoulder. But not only that, surgeons reported fatigue, numbness, and stiffness, not just pain. And I wish I could say that there was a specialty you could go into where you wouldn't have consequences of poor ergonomics and work-related injury, but it really is universal, some more than others. If you're doing any sort of minimally invasive surgery in whichever specialty you're in, endoscopic or minimally invasive surgery has the highest risk for pain and fatigue and other work-related injuries. And if you happen to be a female surgeon, doesn't matter what specialty you're in, this is a meta-analysis of the studies published so far, you're far more likely to report symptoms related to work-related injury. Well, what about us as a specialty endocrine surgeon? So a couple of years ago, you might have received and filled out the survey that one of our otolaryngology residents and I did as part of a study from the University of Iowa. And we sent a questionnaire to AES members and AHNS endo members to look at the rate of work-related injury and musculoskeletal symptoms among endocrine surgeons. Shouldn't come as any surprise, or maybe it does to some of you, that we have one of the highest rates of reported symptoms. So 90% of those who responded to the survey reported symptoms. The most common was pain, followed by stiffness. And what was even more surprising was that a quarter of people, or a quarter of the symptomatic surgeons, reported developing their symptoms during training. So this starts early. And again, very similar to other studies in our specialty, being a female surgeon, you were, again, far higher likelihood of reporting work-related pain and other symptoms. In terms of location, the big hitter for us is neck. 87% of us have neck symptoms. Shoulder, chest, low back, limb, others, but neck and back. Again, this is very common across specialties. What are the types of injuries? Well, based on the locations of the pain, you can imagine that there will be degenerative changes. Degenerative changes to the spine, both cervical and lumbar, leading to arthritis and disc herniations, as well as degenerative injuries to the shoulder. So why is this? And what are the consequences? Why, as surgeons, are we so prone to injury? Well, first off, we really violate every ergonomic principle in our day-to-day work. So I've put a picture of myself in the OR working from the opposite side, trying to do a neck dissection, as most of us do. We're not working in neutral postures. We're not keeping things in reach. We're not working at the proper height. We have repetitive strain. We don't tend to move and stretch, so we have static load. And then you add some adjuncts to that, and it worsens the situation. Surgical culture is another factor, right? We're trained to push through, forego breaks. We accept symptoms as part of the job. You're going to be a surgeon, you're going to have pain. And I don't know if these traits are ingrained, but they certainly are reinforced over your training. But really, if you're having pain, pain is not a symptom of weakness leaving the body, right? There's something wrong if you're experiencing pain and constant pain. Well, as we know, only a third of surgeons will report their injuries, only a third will seek treatment, and even less than 5% of us actually report symptoms to either our superiors or to the institution. Instruments. So if you're a left-handed surgeon, you know that instruments weren't designed keeping that in mind, but it goes broader than that. Instruments are pretty much designed to meet FDA requirements because, well, is that stapler going to be able to be sterilized? Is that handle going to be able to be sterilized? They aren't thinking always about the ergonomics and the end user experience. And this is particularly important, again, as I said, with female surgeons because they will report frequent problems with laparoscopic instruments, in particular also staplers. I mentioned the adjuncts. Endocrine surgeons often use headlamps and loops. If you're a vascular surgeon, you're using lead aprons, foot pedals. All of these things create postural imbalance, extra loading on the spine, and make us more prone to injury. A lot of us work at hospitals where new technology is retrofitted into existing spaces, and so that's my neck posture, trying to look at somebody's sestamibbe scan before surgery, so I never use the screens that are up in the OR, I just use a regular computer screen. I'm sure many of you can relate to that. I also feel like we used to have some protection outside the OR, someone else would transcribe our notes, or we could dictate and things like that. Now, when you're not in the operating room, you're basically being faced with ergonomic challenges that are usually typical of office workers, right? We're charting in common spaces that are not set up for us from an ergonomic standpoint. And then, of course, we're doing our forward head answering phones and Volt messages rather than either answering pagers. I don't know if that was better, but it might have been better from an ergonomic standpoint. And last but not least, we have workspace and time restrictions. So in industrial engineering, for example, in factory lines, or if you took your car to the garage, they can elevate it, they can remove the doors, they can change the workspace to improve ergonomics. Our patient's body habitus is what it is, right? We can't change that. And so it's really hard to standardize surgeon workflow as you would maybe in a factory line. And on top of that, OR time is money, so taking breaks is kind of frowned upon. Well, what's the end result of all these factors that lead us to have poor ergonomics? The obvious one is work-related musculoskeletal injury, which I've been talking about. And it's important to remember that of those people that report symptoms, 12%, so a tenth, will need one of these three things or more than one of these things. So leave of absence, practice restriction or modification, and if you have a career-ending injury, early retirement. So just think about that, right? You know, 1 in 10 of us, if we think that our symptoms are, almost everyone has some degree of pain, 1 in 10 of us are gonna have to do this. I was one of those surgeons. I took a leave of absence, and I had to restrict my practice. It could be any one of us. It could be you. Aside from work-related injuries, though, there are other consequences. The work-related injuries do affect our productivity, our finances, both personal as well as institutional, but there's an effect on recruitment into our specialty, and then there's an effect on quality and safety in terms of the care we provide our patients. About a third of surgeons report taking their own symptoms into account while they operate on patients. I mean, I know that I don't do the 3-4 centimeter incisions anymore. I just cannot. And so the incisions for my neck cases have gotten larger. That was to set the stage for the problem. I'd like to spend, or we're going to spend the rest of the talk and hopefully a discussion talking about potential solutions. Before we dive into that, though, I'd like to have you just take a look at the Swiss cheese model that's very well known in quality and safety work, but also gained notoriety during the pandemic. When we think about a framework for improving our ergonomics, we have to think in terms of layers. I wish I could say that there was one single thing that would fix the problem. There isn't. There are things that we can do in terms of individual surgeons, you know, taking care of ourselves, PPE, if you will. But there are other layers, and these other layers, they're not just our personal responsibilities. We need our institutional and organizational culture to change, and then we need our environment to change. Ergonomics represents the interaction of a human being with their environment, and for us, that's our instrumentation, our OR table, all the screens we look at, etc. So let me talk about the strategies briefly, and then we'll dive into the nitty-gritty of what you can do today, starting today to improve your ergonomics. So the strategies. So how are we going to improve the current state of ergonomics among surgical specialties? So one is to increase awareness. By having a panel like this, by sharing our own stories, I mean, we reduce the stigma of being alone or feeling alone when you're having these symptoms or a major injury. We also know that there is a woeful lack of knowledge, both in terms of formal ergonomics and informal ergonomics training during residency. I don't know about you, but my ergonomics training was restricted to stand up straight. Come on, stand up straight. What are you doing? So we need some formal ergonomics training. And really, that's a chance for early intervention. The end result of our sort of repetitive strain injuries, the pattern of injuries in residence suggests that if we intervene earlier, hopefully they won't get chronic. And then last but not least, what about the practicing surgeon? Those of us that have already had injuries or have developed, as I say, ergonomic bad habits, well, there's utility to curricula, but also coaching. So now comes the nitty-gritty, the what. Now, at least in the Society of Surgical Ergonomics, when we think about it, we think about things that we can do outside the OR, and then there are things that we can do inside the OR because we have ergonomic challenges in both spheres. We belabor this point with our patients, right? We tell them to sleep, get adequate nutrition, and avoid stress. Well, that's kind of an oxymoron and pretty much impossible in terms of what we do. But there are things we can do to improve, right? Our bodies are our best tool. We've got to take care of them. So resting when you can, minimizing sources of stress, meaning stress you can control versus stress you can't control. And then in terms of exercise, that's the biggest bang for the buck. For those of you who run, fantastic. If I'm running, look for the bear behind me, or the tiger, or something like that, because I grew up in an Indian family where, physical activity, well, I got a C in phys ed. My dad said, oh, great. I don't know what happened.
Maybe we have to run.
Is there a fire alarm? Do we need to run?
May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly.
Okay.
Keep going.
May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly.
Okay. Point. Enjoy lunch for the time being.
May we have your attention, please? May we have your
Can we stand up
attention,
and
please?
stretch while we do?
Trained hotel personnel are responding to the cause of the alarm. Please
Are they saying
remain calm.
trained healthcare?
Further announcements will be
Or
Trained help,
Oh,
I think.
May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly.
Bottom line, you need to incorporate some sort of strength training.
Like, try.
So Pilates,
so we should let's just sit here and wait.
May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly. May we have your attention, please?
Yeah.
May we have your attention, please? Trained hotel personnel are responding to the cause of the
Okay,
alarm.
so Court and I got a message from somebody, one of the staff here. This is about a medical alert. So thankfully, there's about 500 surgeons in the room. If we can find the person, maybe we can help. So we'll try to continue on, and then we'll keep you apprised if anything changes.
Thank you, Barb. Okay, so point I was trying to make before the glaring alarm was that we should incorporate some sort of strength training and stretching routine, whether you do yoga, Pilates, do the workout with a trainer. Building core strength is really important. If you run, fantastic. Outside the OR, we really need to think of ourselves as athletes and have some sort of preventative exercise program. And in fact, there are studies showing that if you do these stretches or some sort of preventative program, it actually cuts back on analgesic use and back pain. So there are several resources. You'll find them on the Society of Surgical Ergonomics website. But in fact, the American College of Surgeons Ergonomics Task Force last fall came out with a document, PDF document that has these exercises, and you can look at those and have them in your break rooms and make sure that people are working to stretch in between cases. That's really helpful. And then paying attention to how we work outside the OR in our desk spaces. So your office space and working at home, it's really important to have the monitor sort of lined up in front of you, not to the side, slightly downward angle. Make sure you have a comfortable chair that's got lockable wheels. All of these things play a big role. So at your institution, you may have access to an ergonomist. They could come and do an assessment for you in the office, or you should be able to find these resources on the university websites or the hospital websites. Laptops are a big no-no. If you have to work on a laptop doing your EPIC charting, it's nice if you have a external keyboard as well as mouse and a laptop riser, again, to keep those monitors aligned with your eyes. And of course, paying attention to posture while doing your hobbies. So I'm going to finish or stop here and have Andrea talk about the things that we can do in the OR. So thank you.
Thank you. Okay, so now that you have an overview of surgical ergonomics, I'm going to get into some more detailed parts of surgery. Like Geeta, I'm going to start with my ergonomic story. I think that's why a lot of us in the society got interested in the Society of Ergonomics. And as Geeta mentioned, it helps reduce the stigma and helps promote that we should be taking care of ourselves and we shouldn't ignore our pain. So I'm sure a lot of you remember the commercials for the Medic Alert bracelets back in the day where you had the elderly lady on the floor, help, I've fallen and I can't get up. This was literally me about a year ago. I was putting dishes away at home. I twisted slightly and felt a horrible lightning pain in my back, fell to the ground. It was, of course, the first day my boyfriend had gone back to work after working from home for 2 years. So I was stuck on the ground for about 20 minutes. I was actually already in physical therapy for my neck, which I had to cancel from the ground. And I ended up having to take a week off of work because I just could not move. So I had to reschedule all my patients. When I came back, I really tried to reduce my schedule initially, but you guys all know how that goes. And really my first thought when this happened was I was worried about my patients and my patients getting care and getting their operations, which I think, we all put our patients first. And then I started to realize that this may have implications for me later on. I was 37 years old when this happened. I was only 1.5 years into practice, and I started to worry about my longevity as a surgeon. And so I started to think a little bit more about our adjuncts that we use. For endocrine surgeons, these are really important for us. We use loops, headlights. If you're short like me, you need to use steps, pedals, also our shoes, and anti-fatigue mats. So raise your hand here if you think that using loops and headlights increases your pain after operating. So I see a lot of hands here. The study agrees with you. The study looked at 50 surgeons in over 100 cases across 12 different specialties. They used wearable technology to look at our position in the operating room, and they found that we spent 65% of our time in high-risk neck positions and 30% of our time in high-risk torso positions. And if you look at...
For 5 minutes.
May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly.
That is unbelievable. It's a first.
May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly. May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly.
Medical?
May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly. May we have your attention, please? May we have your attention, please? Trained hotel personnel are responding to the cause of the alarm. Please remain calm. Further announcements will be made shortly.
Him just follow us. Maybe it will stop soon. Okay, maybe it has stopped. I'm going to try to continue. So the study looked at head and neck surgeons, and so head and neck surgeons like us spend over 3/4 of our time in a high-risk neck position. So it's no wonder our necks hurt at the end of the day. They did look specifically at adjuncts, and they found that surgical loops and headlights were independently associated with increased time in these ergonomically unfavorable neck positions. They looked at independent risk factors for surgeon-reported pain, which included loops and headlights, as well as longer case length and increased years in practice, aka getting older. And they did find that surgeon self-reported pain was associated with ergonomic risks, so these positions do matter. This other study looked at the angle of the loops, and they looked specifically at the angle of declination of the loop, so the angle of your loops that look down. And that angle is labeled B on this figure here. And they show that if you can maximize your angle of declination, you can decrease your neck flexion angle. And so here's a picture of me with my old loops on the left and then my new loops on the right. My old loops were from general surgery residency. We really had no ergonomic training then. A rep came in, everyone got the same loops, and no one really thought about it. And so I used these all through residency, and then when I became an attending, I started getting neck pain, and my colleague said, you know, you really need to consider a steeper angle of declination. And so I did that, and you can see that, you know, I maximized that angle B and reduced that angle A. Some other best practices, so I know some people don't use loops for their thyroid surgery. If you are going to use them for the shortest duration of time. You actually can take a break during surgery, and we're going to talk more about that later. Again, consider that angle of declination in your loops and aim for a neck angulation angle below 25%, and you want a focal length of about 18 to 20 inches to allow for your elbows to be comfortably at 90 degrees. Similar for a headlight, you want to get the lightest headlight. If your OR doesn't have these, you can talk to your OR about getting them, or you can purchase one yourself. They are expensive, but really it's an investment in you and your career. And most companies do allow you to trial them for about 30 days and return them without any cost. And I've sent some back, and I currently use one that's lightweight and attaches to my loops. Again, with the headlight, only use it when you need it. You can take breaks to put it on and take it off. And then consider lighted retractors as an alternative to wearing a headlight. Again, these are expensive, and your institution may be resistant, but we really need to advocate for ourselves. These lighted retractors are less expensive than the cost of replacing surgeons or time off for injury. And don't forget about table height and positioning. You want to position the bed height to the tallest person operating so that their elbows are 90 to 120 degrees. For me, this is usually to the position of the resident, so I'm usually on steps since I'm 5'3" on a good day. Keep your wrists in neutral positions, avoid prolonged static positions, and then use the bed rotation features. If you find that you're leaning for a long time, remember to rotate the bed towards yourself. Rotate retraction tasks if possible, and then tuck or papoose the arms. And then other things, I know Geeta talked about an ergonomist evaluation. So after I had my back pain, and I was, in pain every day operating for months, I had an ergonomist come and evaluate me. This may be available to many of you at your institution. I was able to access it through occupational health, and they came to my office, they came to clinic, and they also came to see me in the operating room. And so these are some really wonderful pictures of me in the operating room. You can see why I have neck pain. But I think what was most surprising to me was my feet, which was not something I'd really thought about. You can see I'm on a step with a pedal, and so I have a very narrow stance. And when you're leaning, that puts a lot of strain on your back, which is where I was having a lot of my pain. And so I worked with our service line coordinator to really advocate for more steps. Many of you probably have these steps at your institution. They wobble, they're heavy, they're missing foot pedals, they don't have any padding. And so I advocated to get better steps, which are these that are lightweight, they're steady, and I can sort of make a platform in order to be able to stagger my steps. So this is my step setup. And you can see in this picture in the middle here, this is me with a narrow stance leaning. You can see there's a lot more strain on my back, as opposed to if I stagger my stance, I can take some of that strain off my back. And then you can add anti-fatigue mats to them as well. You can also use these on a flat floor without steps. And I would like to make a note that these should never, ever, ever be called princess pads. We should not be looked down upon for advocating for ourselves and our body. Other things to look at are shoes and footwear. I was a Dansko loyalist for many years. My podiatrist recently begged me to consider other shoes, so I now have a cushioned running shoe. But make sure that they're supportive, that they have cushioning, they're stabilizing, a wide toe box, and then have arch support, or if you're me, have room for your custom-made orthotics. I'm going to switch gears a little bit to laparoscopic surgery. Full disclosure, I don't really do much laparoscopic surgery, but when I did, I probably looked like this, which is not how you want to look. which is why I hated laparoscopic surgery. So you want to make sure your bed position is low, so you can, again, have your elbows at that 90-degree angle. Pay attention to where the screen is in the room so that you are looking at it at eye level and not straining your head up and that you're not moving your neck with it. And then a few other best practices for laparoscopic surgery. Consider actually doing a split leg approach and standing in the middle of the legs. That can improve ergonomics. And then just be aware of some of the hazards when you're passing instruments in the dark and you have all this tubing, that it can cause hazards and decrease efficiency. Some more laparoscopic best practices: you can use trigger locks and ratchets to minimize your sustained gripping or squeezing on instruments. And when available, use the articulation or rotation to avoid awkward arm movements. And then there are many different types of handles for the laparoscopic instruments. You should see what your institution has and try them out and see what works best for you. There's a study of surgeons and their preference was wide, but you should see what works best for your hand size and your flexibility. So now we're going to talk a little bit about robot-assisted surgery, and I think people think that this is sort of the answer to our ergonomic problem that's going to solve all our ergonomic issues. But we actually do have a lot of pain associated with robot surgery. The back pain does go down because you're sitting, but neck pain and finger pain and wrist pain go up. So in this picture on the left here is a surgeon at the console, and you can see that they're spending a lot of time in this high-risk neck posture and shoulder position. And while this may be great for taking a nap at the console during a 10-hour robot Whipple as a fellow, not great for actually operating. The one on the right is an ergonomist, and they did a study and they showed that if surgeons use the ergonomist posture, that their pain decreased. And so again, we have on the left, this is what you should not do. On the right is what you should be doing. So you do want a chair that can lock and it has lumbar support. You want your knees at a 90-degree angle. Again, you want that elbow angle 90 to 120 degrees. Make sure that your back flexion is less than 15 degrees. Use the clutch frequently so that you're not in awkward wrist positions. And keep your feet on the floor. And so additional tips for the robot: you should adjust your stored ergonomic settings every time because your posture and things might change. You should adjust the console to be a little bit slightly higher and decrease the viewfinder angle so you can decrease your neck strain. And then check yourself periodically intraoperatively. You might forget because you're sitting and it's a little bit more comfortable than standing, but you may find that you're in sort of a clenched position and you need to adjust. Again, clutch often for your wrist and fingers, and even take micro breaks for your finger and hands. And now I'm going to turn it over to Phil.
Thanks, Andrea, and thanks, Geeta, for inviting me, and thanks to the AAES for having us. We'll start with a poem. I'm not going to read it, but I asked ChatGPT to come up with a surgical ergonomics poem in the style of Amanda Gorman, and they, it came up with the title, and it also did the italics at that bottom paragraph, and you could just imagine Amanda Gorman belting that out at the AAES symposium. But it makes me redundant. AI, that last paragraph is all that you need to know. So thank you very much. We'll move to Game of Thrones. So that is an MRI of my neck. I've had about 4 over the last 12 years. It actually is a pretty good MRI. But 12 years ago or so, I was doing a thyroidectomy, and I felt like a knife just went right into the center of the back of my neck. And it subsided, but I tried everything: acupuncture, physical therapy, NSAIDs, and I have chronic neck pain. It's about a 3 or 4 out of 10 all the time. It doesn't seem to be any disc or bone problem. It's some soft tissue thing. But why does it happen? We've already heard. This is me on the right with this forward neck posture. That's doing a thyroidectomy. Fixed, sustained postures. So 3 thyroids in a day, that's 6 hours. Maybe for Herb Shen it's only 2 hours, but for 6 hours, of flexed neck, it is not how we are supposed to stand. And so that's the CVA. If the craniovertebral angle is less than 50, that's high risk. Some people use the cervical flexion angle from the vertical as another way of describing it. So NIOSH has this hierarchy of controls, and how can we deal with the hazard? The bottom is easy to do, and this is most of what we've been talking about with administrative controls. And the top is harder to do, but it's much more effective. So microscopes, the first M. A colorectal surgeon came up to me when I was talking to him about my chronic neck pain. He said, Phil, have you tried the operating microscope like neurosurgeons use? And I'm saying, Maher, what are you talking about? He says, try it. And so I Googled it, and about 10 years ago, there was a study on using the operating microscope for thyroid surgery, but it wasn't for ergonomics, it was for recurrent laryngeal nerve and parathyroid identification. So I encourage everyone in this room to think outside the box if you're having some ergonomic problems. So here's the operating microscope. This is a Zeiss Kenevo 900. It's a lot of technology in that $850,000 machine. There's another one that's a little cheaper called a Tavato 700. So those are Zeiss scopes. I phoned my neurosurgeon. I said, hey, can I try this for thyroids? And he was very actually excited to help me, and he came into the room. We played around with it a couple of days before I used it for the first time. And here I am using it on the right. And so you can see I'm standing up like a meerkat. I mean, it's the most amazing posture you can imagine. There's some other, so let me show you this craniovertebral angle. So it's almost at 50, but before the operating microscope, it was 10 degrees. So, I mean, that's high risk on the left. It is so awesome. I cannot tell you how awesome that machine is for my neck. It has some other side, attributes which are awesome. The lighting is unparalleled. No head, whether it's mine or a resident's head, will get in the way of the light. You can zoom up to 10 times, a little bleeder, pesky bleeder on the nerve. You can lift it up with a little micro scalpel and clip it tangentially, 10 times mag, and then you zoom back down to normal. It is an amazing machine. I write about this in a little editorial thingy I published recently in AJS. So the other M is micro breaks. So there is data on doing timed micro breaks. They are mandatory in my opinion. Sport athletes do it all the time, before or after. They're running around playing soccer. They might stretch while they're waiting for a penalty kick or whatever. So a micro break, and it has been studied mainly by Susan Hallbeck, who's a PhD ergonomist at Mayo Clinic. She did this case series of 56 surgeons doing micro breaks every every 20 to 40 minutes for about 1.5 to 2 minutes. And so how did surgeons feel after? Most felt a lot better doing micro breaks during surgery, physically, mentally, and reduced pain. Absolutely. In my case, I do them all the time now. It used to be a big hullabaloo. Oh, I'm doing a micro break, but the whole room does it now. I just step away. If you're doing a frozen section, if you're walking around to the other side to do a thyroid, do a micro break at that time. So there is a QR code and the website for the OR Stretch, which is the branded Mayo Clinic version. And everyone, I don't hear any tinkling of forks and knives. We're going to do a micro break, so everyone stand up. This is the Mayo Clinic micro break. It's 1 minute in length, and I'll just start the video. There should be some sound. Oh, I can go back. Oh, hang on, I knew I was going to have some IT issues. Oh yeah, I can't hear the audio.
I guess I'll provide the audio. Big breath in, lift your shoulders back, and now arms forward, back facing you, facing outward, back to base position. Stretch your neck back, forward, towards your chest, back to base position, right foot forward, turn your head to the right, back to base position, tilt left, back to base position, left leg forward, turn left, tilt right, back to base position. Look up towards the ceiling. Take a big breath. Then an abdominal crunch. There you go.
Awesome. So it's really easy. You know, when I first started to do this because of this study, a lot of folks in, anesthesiologists started to do it, scrub nurses do it, and it's just no big deal anymore. It's just very easy to do. All right, the third M, the MLB part. I want to talk about some research areas that we have major opportunities for in here. Currently, it's basically a black hole. Most of the data is survey data. So students, residents, fellows, the world is, it's out there for you to just explore. The research possibilities are endless now. One area that I'd like to talk about is we have a major deficit in the reporting of our injuries as physicians. And when I had my neck pain for 2 years, I went to an AAES meeting and I asked past President X, hey, I whispered with my tail between my legs, hey, do you have neck pain? And past President X said, yeah, and we talked about it. And then I asked past President Y, hey, do you have neck pain? Because we can't talk about it, right? Yes, I have neck pain. And so, basically the culture of not talking about it, we have to get this dialed in. So here's the deal. Contrast that to the workers' compensation information system in California, where a firefighter or a police officer gets injured, they see their doctor, the doctor fills out a 2-page medical assessment, and then sends it to this WCIS system, and someone inputs the data. So in 10 years, there's 6 million injuries, but mainly, and you can get folks at Rand down the street from me, and Masha, and Dr. Ye, 108,000 firefighter injuries in this database, 200,000 police officer injuries in this database, and they can study it. So, look at, they really were interested around at the firefighter component, but compared to everyone else, that's a really tough job ergonomically, an injury-prone job. So wouldn't it be amazing? We need a surgical database on injuries, and somehow AAES or ACS, we got to get one going. Maybe tag it to SESQUIP for endocrine surgery and have the surgeon side of things. And if you're injured at work, your neck hurts, you dial it into your little assessment of your, didn't injure a nerve today, but my neck hurt 7 out of 10 today. So you guys, all these young folks here, these med students here giving amazing talks, you got to take over this. And likewise, the workers' comp has injury data on actually what body part is injured. So, the firefighters looked at this data and said, hey, maybe we need to change the way we're holding our hoses. I can't even carry my garden hose, but these guys have to carry, these huge fire hoses. And data like this, actually, they address, okay, well, we have to change the way we hold these hoses. I'm also formulating a study, and I welcome any input, any collaboration. If you're not a baseball player, and I wasn't, I never have been actually, but until this guy moved in beside me, but the pitchers in the MLB will rarely go above 100 pitches per game. There's definite injury. The longer innings you pitch, the more innings you get injured. So why do they limit their pitches? Because they want to preserve their investment. So are we preserving ourselves? I think there's a pitch count, a number of cases per week, that if you exceed it, I think that our careers will be shortened. There's also actually an ongoing study sponsored by the Society of Surgical Ergonomics, but the lead is Susan Hallbeck, who I mentioned. And she's looking at hand size. And isn't it ludicrous that on the left, the petite hand and the large hand have to use the same instrument? It's kind of ludicrous, right? Would my 7-year-old daughter wear my shoes? No. But these petite-handed surgeons have to use these, devices that aren't really fit for them. So you take your phones and you can get that QR code and actually submit data to help this study sponsored by the Society of Surgical Ergonomics. And I think this is my last date, another plug for Society of Surgical Ergonomics. Save the date, our second annual symposium, September 8, 2023. And there you go. Thank you very much.
Again, I'd like to thank the council and the program committee for a chance to speak to you all at this session, and we are now open for questions. So come on up to the mic, and we'd love to hear from you. Go ahead.
Okay.
Up front, Mike.
Carmen Solorzano of Vanderbilt. Excellent talks and excellent topic to discuss. As I think about let's say our institution is building a new tower, new operating rooms, and I wonder what you have seen in your visiting multiple places, giving talks and having this organization. What is being done by institutions when these new ORs and new places are being created? Do they have an ergonomic expert looking at these things? I know you said that we retrofit spaces. We get asked to contribute to what goes on into these ORs, the offices, et cetera, but I don't remember ever being asked about ergonomics.
Carmen, thank you very much, Dr. Solorzano, for that question. And you're absolutely right. There is a mix, but the majority of institutions building new towers, new OR spaces, they do not have an ergonomist on them. And they certainly don't have surgical ergonomics input from our standpoint. Some do. And part of it has to do with the fact that usually for a mid-sized institution, there will be one ergonomist. I don't know what Andrea found at her institution, but at my institution, we had one ergonomist for the entire hospital. You have to wait 2 months for them to come to your office to do an assessment, let alone having the bandwidth to come to the OR. So having that one person on all these architecture meetings, et cetera, absolutely, in the design of spaces, they should be looked at, and that is something that we have brought up with our surgical services committee. I'll let Phil and Andrea answer for their institutions. So.
Yeah, I don't know what input they have requested from surgeons in terms of building new ORs, but they certainly should. In terms of ergonomists, I think we have a few that will come to your office and clinic space, but there was only one who would actually come to the OR. So we had to find time and arrange for that.
Yeah, I can't comment on the building design either, but there's very few surgical ergonomist PhDs interested in surgery. And it would be amazing to work at the Mayo Clinic with Susan Hallbeck. She's seeding some throughout the country with her fellowship program, but our ergonomist at our place has no expertise, zero, about the operating room. So I asked her if she'd come in, and she basically said she doesn't have the expertise. So even that at a ground level needs to start to build up across the country.
Left mic front, yeah.
This is an excellent panel. Thank you very much. You don't forget about thoracic compression fractures as we age. That's a decade of unacknowledged pain. But my question for y'all is, the patient has a BMI of 61. It's mostly upper body. The neurosurgery equipment is not available. Any pearls other than dictating a 22 modifier? Any pearls for managing that?
Dr. Carty, thank you for the comment and the question. My personal experience, as I relayed during the first part of my talk, is I can't do those small, it's a maximally invasive incision. I use every energy device I can, and the resident doesn't do as much of the case because I just want to get it done. I get trapezius Botox injections so that my neck isn't constantly tilted to one side, because that was the end result after 15 years. So whatever I can do to reduce the pain, those are the only pearls I have for the regular open surgery.
Yeah, no, I think those are challenging, especially me being a very petite surgeon. I think the same thing as Geeta, I'll make a bigger incision because I think you need that in order to do the operation. I think taking more frequent micro breaks during those cases, making sure to stretch afterwards, maybe getting a massage after, doing other things to take care of your body. I think it's hard during the case to really be able to modify things.
Before Phil, go ahead, Phil.
Yeah, I'd just like to add, I also do surgical oncology, so for a huge retroperitoneal sarcoma, I tag team with my colleague, and I'll take an hour break, and they'll come in, awesome surgeons. Victoria O'Connor saves me all the time, but why not tag team more just for a thyroid? You might think it's weird to get a colleague to help out, but it's like many micro breaks, and get a colleague to tag team with.
The biggest bang for the buck, I would agree with my co-panelists, is really incorporating those micro breaks and stretches while sterile. We showed you something from the Mayo Clinic, but really you could just put a timer on your phone. If you've been treated by a physical therapist before, you know your target areas, just stretching those, just taking that break. It's great for the physical ergonomics that we're talking about, but also cognitive ergonomics. How many times have we gotten frustrated looking for a parathyroid and then just stepped away from the table and come back and find it? There is a real thing.
Sam Snyder from Doctors Hospital, UTRGV in Edinburgh, Texas. I have a comment that is very similar to Dr. Cardy's. It pertains to what I deal with working in the fattest county in the United States, literally. The problem is working on the neck in a patient that has a BMI of 55, 45 or greater. So I have come to dread them because I know I'm going to be leaning over, particularly if it's a cancer case, for a long period of time, and I feel it in my back. So I'm asking, do you have any data that relates to BMI of the patient when we're doing neck surgery? Because I think that would be very interesting. Maybe I should only schedule one of these big patients per day and look for the little ones.
That's what SESQUIP needs to do. So the BMI should, I hope, I actually don't participate in SESQUIP, but maybe a little field for BMI, and then add the whole thing about neck pain, back pain, surgeon ergonomics. It's ripe. I'm a med student. Come on, there's all these med students here. Take it over. Let's go.
Yeah, Dr. Snyder, not to minimize, what you said and what Phil is saying, and that's the crux, right? So we don't have the data because we don't report. How many of us have ever gone to occupational medicine and said, this is from my operating? We just do our standard diet, NSAIDs and coffee, and move along, right? Andrea. Sorry.
Yeah, no, I agree with that we need more data. Perhaps we had something like the Simple app that they had for teaching residents, but instead of a Simple app, it was about your pain, and we circulated it, and people input about the case, the length of the case, BMI, and then their pain scores after. We could collect data.
Very good.
Thank you.
Sean Kurgan, I work for a device manufacturer exhibiting in the hall over there, Hologic. I just want to talk about the data, and does AAES collect glove size and height of the membership as part of like your normal membership database, which I've talked to the gynecologic laparoscopists and other kinds of surgeons, and none of these small specialty societies do that, and I think that would be very helpful to be able to communicate to manufacturers, number one. And number two, on reporting, there's post-market surveillance, like complaint data that you probably do if there was some issue with your patients. But if you have your own complaints, the manufacturer has to collect all of that data, and if it spikes, they have to do stuff to address that. So if you're not making those complaints also directly to the manufacturer, you're doing yourself a disservice.
Thank you very much for your comment and for coming up to the mic and relaying that. And actually, that brings up an important piece, another piece for the Society of Surgical Ergonomics. I'm sorry, the lights are really bright. Because of the lack of data, that's why that hand size study is ongoing. And the hope, one of the missions of forming the society was to actually be able to set standards, right? So OSHA doesn't have any oversight over our workspaces, right? I think if they came into any of our ORs, they'd shut us down. The purpose of having the society, a major mission, as I said, is so that we can actually set the standards. Maybe staplers and instrumentation needs to come in two sizes. It's a bimodal distribution of hand strength and size. And glove size doesn't always correlate with strength, which is more related to hand span. They bring up an important point, and we're hoping to collaborate with industry to do that as part of the society and its mission. Any other comments from Andrea or Phil related to that? No.
I think you covered it.
Dr. Nabnet, last but not least.
Thank you, Barry. Oh, that's really loud. Barry Nabnet, University of Kentucky. This has been a fantastic session, and I think one of the things we're really talking about is culture. And where I had the privilege to do my fellowship in France, ingrained in the culture was taking breaks during the operating room. In fact, it was not uncommon during a very long operation, we would break for lunch. And the outcomes of the patient were the same. So I think, our nursing colleagues take breaks frequently during the operation. Yeah. So I think, we need data. So I applaud your comments about trying to collect data and to understand. But then I think as an association, we have an opportunity to advocate for timed breaks. Not that we want to be regulated. I think we have to be careful what we ask for. We don't want to be regulated, but to get that ingrained in the culture in the operating room is the charge before us. But this has been a great session. Congratulations.
Okay.
Thank you.
Thank you.